My name is Seymour Katz. I'm from the Albert Einstein College of Medicine and from the North Shore Long Island Jewish Health Systems, and I'm privileged today to have with us Dr. Christina Surawicz from the University of Washington in Seattle and Dr. Darrell Pardi from the Mayo Clinic, Rochester, to participate in a panel discussion on the management of the elderly IBD patient. We are privileged today to have a very distinguished faculty to discuss an emerging and incredibly important subject of the management of the older IBD patient. We're here today to discuss a subject which has become increasingly important because of the scope of the problem emerging, particularly since January of 2011, where some 79 million baby boomers have turned 65 and will be doing so at a rate of 10,000 per day, approximately 4 million per year over the next 19 years. Now, it turns out that about 1/3 of these patients, of the IBD patients, are older than 60 years of age, which has an equal male to female ratio. It's important to remember that although most of them are under 70, from the 60 to 70-year-old range, we still see 25% of these patients in the range of 70 to 80 and 10% over 80. Now, in one study, it's impressive to note that although the IBD older patient accounted for only 15% of all of patient population, they were responsible for 25% of all IBD hospital admissions. So we have here a population with a greater number of hospital admissions, higher mortality, longer postoperative stays, and greater comorbidities, problems with polypharmacy, and problems with social adjustment as well.
I'd like to talk about the diagnosis of inflammatory bowel disease in the older adult. I like to think of ulcerative colitis and Crohn's disease, the two types of inflammatory bowel disease, as siblings. They're related, but they're not identical. Ulcerative colitis is mucosal. It almost always starts in the rectum, but it can involve the left colon or the entire colon. And the most common symptoms are rectal bleeding and bloody diarrhea. When it's severe, patients can have weight loss, fever, and abdominal cramps. The major difference with Crohn's disease is that it's patchy and it's transmural, and importantly, it can involve any part of the GI tract. So 80% of Crohn's disease will involve the small intestine, 30% involving the ileum alone, 50% involve the ileum and the colon, and the most common presentation that I see of Crohn's disease is with ileocolitis. 20% of patients will have colon disease alone, and then perianal disease is very common, up to 30%. And the symptom of diarrhea, unlike ulcerative colitis, it can be bloody, but it can also be watery or malabsorptive. And abdominal pain is very common because the patients can have inflammatory mass due to the fistulizing disease, or they can have obstructive symptoms. Systemic symptoms, again, when severe, can include weight loss and fever.
It's interesting that you bring that up because keeping the elderly IBD patient on the radar screen is really important, because in our population of over 3,000 patients, we've noticed that there's a delay of almost 8 years, from 6 to 8 years, before that patient is fully diagnosed with IBD, as opposed to the younger patient where it's a 2-year delay. And one of the curious things that happens is because so many of our patients have colonic disease and distal disease, they may actually report constipation. And they have a paradoxical constipation due to the inflammation of the distal colon. So this tends to throw off the thinking about IBD when in reality it should be on your proverbial radar screen.
Yes, hi, that's a good point. There is evidence that the older patients with ulcerative colitis are more likely to have distal colitis than pancolitis. And for Crohn's disease, more likely to have isolated colon disease than the general Crohn's population.
Well, the extraintestinal manifestations are important as well. And the ones which are correlated with disease activity, meaning when the colonic disease is severe, the extraintestinal manifestations are worse, are the eye disease, so this would be uveitis and episcleritis. For the skin, it's the erythema nodosum. For the mouth, they can have very painful aphthous ulcers. And the arthritis is typically the large joints and peripheral arthritis, symmetrical knees and elbows. So when the colonic disease flares, these extraintestinal manifestations may flare as well. But there are other extraintestinal manifestations which do not correlate with disease activity, but which can be very bothersome to the patient, especially pyoderma gangrenosum, which can be very confused with other abscesses, which can be confused with spider bites, for example. The central ankylosing spondylitis or spine arthritis does not correlate with disease activity, but is something that we see in the older population, as we see ankylosing spondylitis without IBD as well. The patients are more likely to have kidney stones and gallstones as complications of Crohn's disease. Osteoporosis, obviously a big problem in the older patient population. And with Crohn's disease and fat malabsorption, we can see vitamin deficiencies of the fat-soluble vitamins, especially D, A, K, and E, and then also vitamin B12 if there's significant ileal disease.
It's interesting that when we noticed in our hospitalized elderly population that some 55% of them were protein malnourished. And many of them come from facilities where they may not have such vigilance about their intake. And what worries us also is the osteoporosis leading to fractures. We have about a 40% fracture rate. Now, it is true many of them are postmenopausal women, but how much of this is due to the cytokine activity of the disease versus the medications, not just steroids, but the other anti-inflammatories that we use. And it's a real problem in managing the patient with DEXA scans and up to the stage of using bisphosphonates. And all this is compounded by the polypharmacy. So many of these patients are on so many medications. We took a picture of one patient of ours and we said, I want you to, don't bring in the pills. Don't bother with that. Just line up all your pills, all your bottles, and take a picture of it. And it turned out that he was taking an average of 26 tablets a day. And that's if he could open the jar to get the pills out.
You know, and I think the point about nutritional deficiencies is underappreciated. Hospitalized Crohn's and ulcerative colitis patients have a very high rate of vitamin and mineral and protein malnutrition, and even outpatients with Crohn's disease, it's not insignificant. So I think a low threshold for screening for vitamin and mineral parameters is important. And with regard to the extraintestinal manifestations, in the elderly, there's really no evidence that they're very different than in the younger IBD patients.
That's good to know. Darrell, let me ask you, what vitamin deficiencies do you measure and how frequent? What vitamins do you measure and how frequently do you screen patients?
So for Crohn's disease, the fat-soluble vitamins, as you mentioned, A, D, and E, INR for vitamin K, B12. Then I'll check folate. If someone's got a lot of diarrhea or weight loss, I check minerals, zinc, selenium, magnesium,
and how often?
Calcium. It depends how they do. At diagnosis, very commonly, especially if there's weight loss, and then during the course, if there's a severe course.
The malnutrition is really a major problem, so much so that when our surgeons see an albumin that's below normal in the elderly patient, they get hysterical about operating on such a patient because the two risk factors in our population have been not only the older age, but the fact that their albumin level and their proteins were so low.
Yes, we have the same experience as well. Do you think the malnutrition is more malabsorption or they're just not eating?
I think in the absence of Crohn's disease, where we don't have a multifocal, multicentric small bowel disease, I think it's actually inadequate in nutrition. And no one's watching the store. They really are not.
What do you mean by that?
Well, they're not really, many of them are living alone. And the problem of living alone is that it compounds the risk factors because they don't have a social setting which engages in adequate activity. And I don't just mean senior citizen centers. And what happens is that they tend to eat less, skip meals, sleep longer, and as a result, the nutrition takes a hit.
Yeah. Well, let's move on to just the differential diagnosis. With ulcerative colitis with acute bloody diarrhea, the most common thing we think about are infections. So typically Campylobacter, Salmonella, and Shigella. These would be the top three, but we also need to remember Shiga toxin, E. coli. Ehrlichiosis has been described as causing a chronic colitis. I don't know if it actually causes chronic colitis or whether it just is triggering inflammatory bowel disease. The other thing to really think about is ischemic colitis. These patients typically have a much more acute onset of bloody diarrhea and they have more abdominal pain. So that's a little bit different than ulcerative colitis, where abdominal pain is not such a big player. The typical location is the splenic flexure, so they will usually be rectal sparing, and that's another key that differentiates from ulcerative colitis, where the rectum is almost always involved.
Unless they're taking rectal therapy.
Meaning the rectum will look normal if there's rectal therapy.
Yeah. It can be a great disguise.
Yes. Radiation proctitis or colitis is usually not a difficult diagnosis to make because you have the history of pelvic radiation, usually for prostate or cervical cancer. The rectum is almost always involved. These patients usually have more bleeding than diarrhea. So this is usually not a difficult This is usually not a difficult diagnosis to make. And then finally, we have to be remembering the medications that the people take. The older people are more likely to take nonsteroidal drugs, and these can mimic inflammatory bowel disease by causing strictures or bloody diarrhea or ulcers, or they can exacerbate flares of IBD in patients who already have it. There's a lot of information now about isotretinoin and its association with inflammatory bowel disease. This is a pretty unlikely medication for an older person to be taking.
I think it's important, at least in our population, they actually bring in everything that they're taking. So many of our patients are taking herbal remedies and stuff from the health food store, which isn't FDA regulated, and we have no idea what the contents may be. And indeed, many of them are swallowing pills with lactose in it, which may generate diarrhea, or even sorbitol-containing products, and we may be chasing an IBS-type pattern instead of an IBD pattern. But it's really astonishing to see how much of the, quote, alternative complementary medications that are out there that your patients take.
Yeah.
I mean, I have patients who I can take 6 months to try and convince them to take 6-MP, but the next day they come in swallowing seaweed and shark fins. So,
and with regard to the NSAIDs, it's important to ask specifically about that because many patients don't consider those medications or forget to put them on their medication list.
Yep.
Particularly if they're going out to play golf or somewhere, they don't tell you that they're taking 2 aspirin or 2 Advil.
The differential diagnosis for Crohn's disease can involve many of the same things that we think about with ulcerative colitis, some of the same infections. But one infection to really think about that looks like Crohn's disease is Yersinia, because it causes an ileocolitis that looks like Crohn's. The biopsies can show granulomas, which is the histologic hallmark of Crohn's disease, and they have a reactive arthritis that can look like the arthritis that we see with IBD. The other 2 things to think about are tuberculosis and amoeba, and both of these pathogens have a predilection for the ileocecal area. So the symptoms may be atypical, they may be more abdominal pain or guaiac-positive stools or occasionally diarrhea, but if you see ulcers or a destroyed ileocecal valve or segments in this area, make sure you take biopsies and make sure you look for amoeba and TB, and especially PCR for the TB.
And I would also emphasize that with the increased immigrant populations that we're seeing, where we are, particularly from Southeast Asia and subcontinent of India, TB and, of course, some of the parasitic diseases can be a terrific mimic of what we're doing. The disguise from IBD may often be impossible to detect.
And that's exactly the patient population in whom I've seen this. And I even saw a case of schistosomiasis that I was sure was tuberculosis until that diagnosis came back. Looked just like TB of the ileocecal valve.
And when you're thinking of those things, it's important to tell the pathologist that that's on your differential so they can look for it as well.
Absolutely. Ischemic colitis, again, has the abrupt onset, mostly pain and bloody diarrhea in that typical area. But another thing to remember is segmental colitis of diverticular disease, because this can mimic Crohn's disease because you have a segment in the, usually in the sigmoid area with inflamed mucosa, a short segment, maybe some ulceration there. Biopsies are nonspecific. It can look exactly like Crohn's disease. And there's some concern that it may actually be an overlap syndrome, but this is obviously still an area of great debate and one of very high interest because there is so much diverticular disease as people get older. And then finally, medications, again, nonsteroidals are the one to really look for because the strictures and ulcers can certainly look exactly like Crohn's disease.
I would add also potassium preparations at this point because we've been fooled enough times on capsule when we're picking up ulcers when in reality it may be due to that supplement.
So the diagnostic approach then should be getting a good history, finding out whether the symptoms are chronic, acute, how long they've had the symptoms, what medications they're on, is there a history of radiation. And then I've had patients in whom the only clue for celiac disease was the family history of celiac in an older patient. And of course, a family history of IBD also is a good alert to that may be the diagnosis here. Physical exam is usually not diagnostic. It may be suggestive if there's pallor or weight loss. Abdominal tenderness or a mass may be your clue for Crohn's disease. And again, you want to look for the skin and the joint manifestations. Chemistries are important as well as a CBC. Anemia is common. It may be multifactorial, chronic disease, iron deficiency, B12 deficiency, folate deficiency. Chemistries are important as well as liver tests. And then inflammatory markers. We order them, but I'm not sure that they're really as accurate in the older population or even in the younger population. We usually order a SED rate and a CRP. And we always have to look for pathogens as a cause for or an exacerbation in our patients with IBD. Enteric pathogens, C. difficile, and ova and parasite exams.
Yeah, Chris, I find the inflammatory markers, of course, are not specific. But if they're elevated in conjunction with a proven IBD flare, patient gets better, they go down. In the future, if they come back with more symptoms, you can use that as a screen to whether it's a flare of IBD or something else like irritable bowel syndrome.
Yeah.
We've been using the fecal calprotectin much more frequently and found it to be much more sensitive to the actual inflammatory bowel population than CRP because of the multiple other contributing diseases.
And do you use that to follow the patients?
I do. It's not predictive. In other words, I can't tell what's going to happen, but sometimes I need to know whether this is, activity of disease that's going on versus, say, a superimposed IBS type picture. One thing I would add and to compliment you on is we include a tissue transglutaminase on almost all of our patients the first time we see them because the incidence for celiac disease is far more prevalent in our population, and you can have both IBD and celiac disease.
So if I can pick up on one of your comments, the SED rate and CRP are not entirely sensitive.
Right.
So if you have a patient with symptoms and you check those, they're normal, it does not exclude the possibility of active inflammatory bowel disease.
Yeah, I've seen that too. And so if they're normal, they still may have active disease, then I tend not to want to follow that or to use that as an indicator of disease activity in the future. So accurate diagnosis, we do need to rely on endoscopy and biopsy. For colonoscopy, don't forget to biopsy normal areas as well as abnormal areas if there are skip areas. If you suspect Crohn's disease, do consider doing an upper endoscopy and biopsying the small bowel, sometimes the stomach. And then capsule has been really helpful for us to diagnose small bowel disease in areas where it wasn't obvious otherwise. Sometimes you don't want to start with endoscopy. Obviously, the patient is acutely ill. You don't want to set them up for a full colonoscopy. If a patient has obstructive symptoms or perforation or abscess or significant fever, you may need to start with cross-sectional imaging of the abdomen to make sure that there's not a complication and to avoid any risks of an endoscopic procedure. So the key points are, we are seeing IBD in the elderly. There are other diseases that we see in the elderly that make this diagnosis more difficult. Diverticular disease, ischemic colitis, and infections. The proper workup is key. And most importantly, I think, is just to be aware that the older patients can have IBD. There is that second rise in incidence in the older IBD, in the older patient population.